المناسبة هو البيدياتريك سيمبوزيوم. شوفوني بعد ساعة.
ايش اخر ان شاء الله.
بعد 3 ساعات حتشوفوا اشياء غريبة عجيبة.
لو سمحت ايه هي الاشياء الغريبة العجيبة؟
يعني اشخاص غرباء واشخاص مرغوبين واشخاص غير مرغوبين. خلاص يلا على الشغل. We'll start at 2 p.m. sharp, okay? Good, the voice is good, huh? I can start to sing or not yet?
Pour avoir été un jour le premier à te caresser jusqu'à te brûler, pour avoir osé au creux de mes bras faire naître la femme qui dormait en toi. Je me sens coupable de t'avoir oublié.
Good afternoon. On behalf of the Symposium Organizing Committee and on my own behalf, I wish to thank you for attending the first pediatric symposium of Dr. Symposium Hospital. To all speakers and participants, I extend a hearty welcome together. I trust that, inshallah, we shall make this symposium a wonderful experience. Now it's my honor to introduce Dr. Basil Faqih, our Director General, who will talk about the opening symposium.
Assalamu alaikum and good afternoon, ladies and gentlemen. It's nice to see such a big attendance to one of our educational activities, regular educational activities. I would like to thank the Department of Pediatric, represented by Dr. Rola and Dr. Arman, in organizing this event. The objective is to increase awareness and improve the continuous education amongst our staff for DSFH and for the local community. We have big plans for the Department of Pediatrics, working with the department on development of a residency program. Inshallah, it's going to be the first of its kind in the private sector, promoting an academic approach to care and a process where our physicians continue to learn and develop themselves and their clinical skills and experience, and also enhance the ability of our junior physicians and provide them with a better opportunity for a career path. Without further ado, I will leave you to enjoy the conference, and thank you very much for your attendance.
Now Dr. Rola Soliman will talk about her speech on behalf of the scientific committee and also on behalf of the pediatric department.
Good afternoon, ladies and gentlemen, Dr. Faqih, dear guests, dear colleagues, and DSFH staff. It's my real pleasure, on behalf of the Department of Pediatric, to welcome all of you this Thursday afternoon. I'm sure that many of you have changed their plan of weekend, leaving their families and sacrificing their time to be among us. But after all, sacrifice is a package, isn't it? This is what it means to be in the medical field. As is, being a pediatrician is hard enough mission. Working at the SFH is more challenging. This is a highly reputable private hospital that has a history of more than 30 years of experience and dynamic healthcare model. Across generation, the SFH leader were up to serve the community, strived and continue to strive to provide the best healthcare to this community by applying the principle of quality and service excellence. In this, we are today here just to see our pediatric experience. The next hour, our consultant will be presenting for you short cases, about 20 minutes each. And these cases are from our exceptionally rich day practice. We have the chance to examine, and we feel professionally obliged to share with the medical community what we have this chance to see. Perhaps you have seen, perhaps you will see such cases, but I promise you, you will not sleep. Dr. Ahmed, our chairman, will be the moderator of session. He will just introduce each speaker, and we will keep the question for the last of each session. We will have 2 breaks, and I hope you will enjoy. I would like to extend a special thank to all presence, Dr. Mazen especially for his continuous full support, the pharmaceutical company for their generous participation in this event, my colleagues who were very enthusiastic preparing this event, last but not least, the Education Center, especially Madame Bassant, and the medical record. I hope the next hour will be of added value to all of you. Thank you.
Good afternoon, ladies and gentlemen. As was mentioned, each presentation is 20 minutes. Please save your questions at the break. Due to the constraints of time, please leave it to one question and be brief. Our first speaker is Dr. Rola Soliman, who has pediatric MD from the American University of Beirut and joined us as a full-time pediatric consultant in 2008. Here we have an update DSFH experience in pediatric Kawasaki disease.
So I think I will be more relaxed talking about our cases. It's okay? You hear me? Well, let's start because we have to run. It's only 20 minutes and it is very important and big subject. Almost every day there is many new up-to-date in this subject, and you will see what we have the chance to see in this hospital. We will present for you all cases seen as Kawasaki disease during this last 4 years. In brief, these cases are, I put here only the positive signs, just not to give you all what we did for this patient, but the end, they were Kawasaki disease. So what is this Kawasaki disease? First, Tulin is a Saudi female of 8 months who presents with 7 days of fever, diaper rash. She was taken as UTI first, given antibiotic, and after 2 or 3 days she started to have red lip and cracked edema of the feet, and she started to have some persistent fever. We did for her echocardiography, it was normal. The platelets were rising, so we gave the first IV immunoglobulin at day 11, and she was discharged on 6 weeks of aspirin. The second case is Yahya. Yahya is 9 months, who was admitted for 11 days of fever with signs of gastroenteritis. And he was initially with the normal platelets that rise later on after the 3rd week. And the ESR was 110. The echo was done after this 2 weeks of fever, and it shows proximal coronary ectasia. For this reason, he was given the IV immunoglobulin with the aspirin, and he was discharged on low-dose aspirin. And this patient has a recurrence after 1 year. He was admitted again in the same picture with increase in his vascular problem. Noura, 2009, she was admitted. She is 2-year female and 6 days of fever with conjunctivitis, edema, cervical lymph node. The platelets were initially normal, up to normal. Then she was rising later on to 1 million. The echo was not 1 million, and we give to her the IV immunoglobulin at day 6. It was early treatment with aspirin, and she is following now for almost 2 years with us, and she is healthy. Carl is a Filipino boy of 7 years. He was admitted with history of fever and neck pain and dizziness. At the first impression, he gave us the impression that it is meningitis, there is neck stiffness. So we did LP, the LP was normal. At this moment, the second day after the LP, he developed cervical lymph node. He has a big cervical lymph node. We did ultrasound, they show multiple lymph nodes. So we think about many viruses, we did culture for virus, and this patient was having the fever who was going to be decreased. I remember very well, I was out in Medina and they told me he started to have red eyes. And I told the resident, okay, you are telling me because I have this Kawasaki, it cannot be Kawasaki. So the next day when I came, the parents took picture for the red eyes, but the next day there is no red eyes, there is nothing, and the baby was afebrile. We discharged him home on no medication. After 1 week, he was readmitted for polyarthritis. At this moment, I was thinking, my God, perhaps this boy has a juvenile arthritis and he is starting to have fever, rash, and arthritis. So we consulted the ID, we consulted the rheumato, and they said, probably it is a beginning. Give steroid. I said, no, since it is the beginning, we will wait and see. We waited for this patient 1 week more, and he rise immediately, his platelets, he got the peeling, and it was a mixed Kawasaki. So this patient did not get IV immunoglobulin. He got only 6 weeks of aspirin. We followed him, and while I was preparing this lecture, this patient came to my clinic with chest pain. I was very afraid. Immediately, we did all the work up, troponin and echocardiography for him. Thanks God, there is no cardiac involvement. Most probably, he got a party of dancing and it was muscular pain. Alhamdulillah. The Ahmed, he was admitted with fever and hepatomegaly, and the platelets rised after the initial presentation. It was with hepatomegaly. Mainly this was GI presentation, and we give him IV immunoglobulin and aspirin. Given antibiotic as pneumonia with cough. She did not improve, so she was admitted for prolonged fever. At this moment, she has only rash. Later on, she developed arthritis, and this arthritis was so strange. I gave the first dose of IV immunoglobulin. The fever did not drop. We consulted the ID, we consulted the rheumato. They said, no, give antibiotic. This is infection, this is rheumatological disease. And I was pushing that, no, it is Kawasaki. After 2 days, it did not improve. I give another dose of IV immunoglobulin. The insurance company were crazy. Are you crazy? Why you are giving to this boy? It's very expensive. Then the mother came to me at night and she told me, I don't know what happened to my girl. She is having peeling all over the hand. So I just kisses her and tell her, thank you, it is Kawasaki. This patient, unfortunately, she got a very severe Kawasaki and she went in complication. She had ectasia. Later on, she was followed by our immunologist. We give her pulse therapy of corticosteroid. Then we followed her with the protocol of corticosteroid, and she improved. At least she did not get the complication of the coronary ectasia, but she is for follow-up. Monica, the last one, no, not the last one. Monica, she was admitted with a fever of 5 days, measles-like, and this one was typical Kawasaki. We give her, and she is fine. Hour is a girl who was admitted with history of chronic GI symptoms and fever. Then the first ultrasound was echocardiography was normal. The second one showed some changes. We give her IV immunoglobulin origin that predominantly affects children younger than 5 years. It's one of the most common cause of acquired heart disease in children in US. And in Japan, because still we have in our country the rheumatic fever who is in behind of the cardiac disease. The history came back to 67 when Mr. Kawasaki described the first series of 50 cases of children who had fever, rash, and that died later on with unknown cause. The epidemiology, we have almost 5 to 15 cases for every 100,000 children as annual incidence. This in USA. In Japan, it's 10 times. In our country, we don't have statistics. The median age usually in you what is the Kawasaki, the physiopathology? As until today, we don't know much more.
The coronary arteries are the blood vessels that supply oxygen to the heart muscle. Because the heart muscle is always contracting, it needs a steady flow of blood to bring in nutrition and oxygen. When children develop Kawasaki disease, the walls of these arteries become inflamed. If we could go inside the blood vessels, we might see something like this. Normally, a cell layer called the endothelium protects the vessel wall and prevents blood cells from leaving. However, some trigger during the development of Kawasaki disease causes the endothelial cells to become activated and causes cells of the immune system to stick to the endothelium and leave through the blood vessel wall. Inflammation in the vessel wall is caused by immune cells gathering in the wall and liberating chemical signals that recruit more cells and further damage the vessel wall. Intravenous gamma globulin, or IVIG, interacts with these cells to quiet down the immune response, although the exact mechanism of how this is achieved are poorly understood. When inflammation occurs in the vessel wall, it it causes the artery to dilate. About 1/3 of children in the early or acute stage of Kawasaki disease will experience dilated or widened coronary arteries. If the patient is treated with a protein solution called gamma globulin or IVIG within the first 10 days after fever onset, the chances of the dilated artery returning to normal size without scarring are excellent. However, if the inflammation is treated late or the IVIG infusion is not effective, permanent damage can occur to the arterial wall. Sometimes this results in a ballooning out of the wall, called an aneurysm. This ballooning of the vessel causes the blood to swirl and increases the risk of blood clot formation. If the blood clot continues to grow, this may result in blockage of the vessel and a heart attack. In many cases, scar tissue will begin to form in the aneurysm over time, and the blood vessel will heal. However, the blood vessel is never again completely normal, and many years after Kawasaki disease, scarring could lead to narrowing of the vessel and again present a risk for heart attack.
This topic was presented by Dr. Jan, who is a pioneer of Kawasaki. I met her in Australia last summer, and she is willing to help us for diagnosis. Usually I do the correspondence with her, so anybody who has any case of suspected or treating Kawasaki, he can contact me. I will give him his email, her email. Now for the causes, it can be, we don't know the cause of Kawasaki. Most probably the speculation now are about viral cause. We don't know which virus is giving this. Many studies about many viruses, but we found the vesicles of viruses in the tissue of those having Kawasaki. The fact that this Kawasaki do not come to patient less than 6 months, usually this is a role of antibodies from the mother. So we think that there is a infectious cause, mainly viral, but we are not sure. There is also genetic, but it is not the only cause. The genetic help because there is running in the family and there is the risk for the sibling. Usually Kawasaki is diagnosed since the 80s. They have the criteria. It was updated later on with 5 days of fever, 4 of the following features: change in extremity, edema or peeling, polymorphous exanteme, usually in the trunk, conjunctival injection, edema and fissuring of the lip, and cervical lymph adenopathy. Usually, these symptoms, I will show you, this is Sydney, our case, who was typical Kawasaki, so the eye, the lips, how they are cracked. The peeling at the next week when she came back for follow-up. This is Carl with the eyes when they took him in picture and they sent me the picture. And the peeling when he came on later on. This is from the internet because I did not see like such a rash. This is the red eye again and the strawberry tongue. This is the diaper rash. If you remember Tulin, my first patient was diagnosed a UTI because she has fever, white VC in urine, and she has this diaper rash. Also, all oral cavity changes from the internet. So we have another problem. When the symptoms are there, Kawasaki is easy to diagnose. The problem when the symptoms are not there and the peeling and thrombocytosis are late. So, and we have to treat early. So it's like if you are in lotto, you are not sure of the diagnosis. For this reason, they describe in the literature 2 types of other Kawasaki, the incomplete and the atypical. The incomplete when you don't have all the symptoms, but you have cardiology referral who said that there is problem. And who said first 10 days is this lady that I met in Australia, and she told me you can give even after the first 10 days. Okay, it varies in the severity. So the echo, the first echo should be repeated at 7 days, at 1 month, and at later on, according to the severity of the coronary lesion. Usually when it's more than 8 millimeter, it's a severe one, and it will give many complications. When there is some signs of severe illness, like the baby is less than 6 months, older than 8 years, male, fever greater than 14 days, persistent elevated ASR, thrombocytosis, all this with cardiac involvement, it's dangerous. This is a picture of a lady who delivered at 31 years, a boy, and while delivering, she died because of coronary ectasia, and her boy also has Kawasaki. So we finished. The treatment is IV immunoglobulin, and we have to give also aspirin There is 2 new treatment, the corticosteroid and the infliximab. There is many study ongoing about the treatment. And from Saudi, we have many studies talking about the Kawasaki. These studies, mainly small series of 20 or 50 cases from Medina, from King Atlas. Thank you. I finish on time.